Welcome to the Art of Pilates. I'm Louise Taube, principal trainer. I am a studio owner and a Pilates teacher, and I train teachers as well. If you'd like to connect with me, you can visit my website for teachers at taubepilates.com. If you're wanting to check out my studio, it's louisetaubepilates.com. And if there's a topic on the podcast that you'd love to hear about, please let me know. All references to HRT in this episode. HRT is now actually called menopausal hormone therapy. So it's now called MHT. So whenever we say HRT, we're really talking about menopausal hormone therapy.
This is Dr Charlotte Ganderton. She is an educator, a physiotherapist, and researcher. Charlotte is based in Melbourne, Australia. She is a senior lecturer at RMIT University in the Master of Physiotherapy course, a clinical advisor for WorkSafe, and works clinically at Alphington Sports Medicine. Charlotte did her PhD in gluteal tendinopathy, which is why I wanted to talk to her today, because it seems like all my clients have got something wrong with their glutes. So, Charlotte, what made you want to specialise or do your PhD in gluteal tendinopathy?
First of all, thank you so much for having me on your podcast. The hip, I'm very passionate about ball and socket joints, particularly the hip. And I think it's so fundamental to how we move in our normal daily activities. And if you're impaired with your ability to, say, climb stairs or go for a walk, it has such an impact on not only your cardiovascular health and also hip pain. And so then you have a sort of a lack of ability to participate in community, health more broadly, but also your ability to connect socially with people. You know, you can't grab a coffee and go for a walk along the creek, for example, because, the undulating ground. And then that no doubt affects people's not only physical health, but their mental health as well. So you're right, it is a hugely prevalent condition, particularly in women and particularly in older women. And we know that as people progress in age, their muscles often lack some strength and atrophy. Rather than muscular tissue, they can be replaced with some fatty tissue. And as well as that, we have huge amounts of hormonal shifts and changes as we get older, and that also increases the likelihood of developing lateral hip pain, or what you referred to as gluteal tendinopathy, accurately.
Oh, good. I wasn't sure if it's still called gluteal tendinopathy or if it's something else now. Because there's also gluteal tendinitis. Is that different?
No, it's not. So you're right. This particular hip pain's gone through a lot of transitions with respect to what we call it. So it was bursitis or trochanteric bursitis, and then it moved through tendinopathy. Historically, we did use tendinitis, and that was used because we thought that it had an inflammatory basis to the presentation, with the word itis or the end of the word itis. But now we have a little bit more of an understanding of what tendinopathy is. And yes, you do get this sort of upregulation of cells and indrawing of water into the tendon, and that disorganizes the collagen and allows for some vascular ingrowth, which can result in sort of a tendinopathy presentation, which is pain of that tendon. There was also an umbrella term used called greater trochanteric pain syndrome. We started using that because that then was a little bit non-descriptive and sort of would pain over that side of the hip. But there's been a sort of a consensus statement to say, well, actually, let's call this gluteal tendinopathy to reduce the confusion that's out there. But yes, it is complex. It generally involves the tendon on the outside of the hip, or the gluteal tendon, and it may involve the bursa. So sometimes people will come back with imaging reports of bursitis, but that is all can be involved in the condition.
Wow. Yeah, because I was wondering what exactly is gluteal tendinopathy, but you've kind of explained it, but I still sort of don't understand. Is there water going in there?
Yeah, so gluteal tendinopathy, I guess by definition, involves either the gluteus medius or gluteus minimus tendons. So those tendons attach to the muscles, so the gluteus medius and minimus muscle, which sits on the outside of our hip. And the gluteus medius allows us to sort of keep a stable pelvis when we stand on one leg. We don't have really good functioning of those muscle groups. What happens is you see when people stand on one leg, that opposite pelvis sort of drops down. And that can affect the way we clear our foot as we step through, or the way we ascend stairs or even descend stairs. We need to be able to control the level of our pelvis and keep it stable. Without those functioning muscles, or without them functioning well, we can develop pain where those tendons insert onto the outside of our hip. So that little bony bump, which most people, no matter how much adiposity someone has, you can actually get to that bump on the outside of the hip. And that bony prominence is called your greater trochanter. And it's that localized discomfort there that's generally one of the main clinical complaints. And of course, it makes sense, because when you lay on your hip, or you may lay on your side at night, that's kind of the bony prominence that will push into the bed. And that's why it's so disruptive to life, because if you don't sleep well, you're grumpy, you don't feel refreshed. I think sleep's so important, particularly as we move through various phases of life. When we know how, when you have a baby and you don't sleep for months, you almost go mad. And the same, during sort of menopause, where sometimes people find it harder to sleep. If you then add pain on top of it, or the inability to get comfortable, life feels a bit miserable.
Yeah. I'm just wondering, because it seems to be a common thing for postmenopausal women, and your study actually used postmenopausal women. And I'm just wondering, if we took HRT, is that going to help with our gluteal tendinopathy?
Yeah, it's a really good question. So during menopause, we obviously have a decline in estrogen. We need estrogen for connective tissue. And so we see with this decline of estrogen, we get, lower bone mineral density, we get some muscle atrophy often, and we see this sort of increase in tendon-based presentations, thought to be due to the impact that hormones have on keeping collagen, keeping tendons healthy. So the thought was, certainly when I started my PhD, the thought was that, okay, well, this condition increases when estrogen levels are reducing. Perhaps if we preserved, I guess, that estrogen in the body, or we supplemented it, would we see a reduction in these presentations, or would we see an improvement in pain? So I guess that's what my PhD set out to find. And I also worked alongside another PhD candidate at the time, Dr. Rachel McMillan, who ended up publishing this study. And we certainly did see a reduction in people's symptoms and an improvement in their outcome measures. So like their questionnaires, like quality of life and their function and their pain. But what we saw it in is actually that change occurred in people who had a smaller BMI, so body mass index, where there are some issues with the calculation of BMI, because muscle is also can be heavy in weight, not just fat. But we saw people on the sort of a healthier BMI actually responded really quite well to the use of hormone therapy. But in those that were bigger on the BMI scale, the effectiveness of that HRT was less. There's definitely an indicator that it's positive in a way. I think as the years go by, we'll see more and more HRT being used for tendon-based conditions. And it certainly gleans some positivity of using that as an intervention. But I wouldn't say that, every woman who has, gluteal tendinopathy must be on HRT. It really requires a full medical examination and to determine if that HRT is reasonable to implement in that individual. Because there are obviously issues with, or potential issues with, any medication. So it's something that I think is going to be looked into further, and we may even see it in other areas of the body too.
Yeah, I know, I have a lot of joint pain, but since I've started HRT, I feel like my joint pain is not as bad as it used to be, and I'm feeling like I'm kind of cheating in a way, because I didn't get the medication for joint pain, but I feel like it's actually really helped me a lot.
And now a word from our sponsor, Taube Pilates. If you're interested in moving well and staying strong as you age, I've created an active aging ebook just for you. This 28-page guide is designed for adults 60 plus, Pilates clients focused on healthy aging, and Pilates teachers focused on working with older bodies. Inside, I share 8 essential exercises to support strength, confidence, balance, posture at any age. You can download it free in the link in the description. Move well, live strong.
But also, like, my other question is, I mean, what causes gluteal tendinopathy? Like, it's not just is it because we're just getting older, or like, do young people get it as well? Like, who gets it? Why does it even happen?
You're right. It can happen in younger people. And there's some sort of indicators of increased prevalence post, total hip replacement or post hip dysplasia surgery. There's even increased prevalence in people with some knee osteoarthritis. But fundamentally, it affects the postmenopausal female population. I guess is the greatest risk factor. And during that time is either a decline in estrogen content or alterations in our hormones. So I think a hormonal driver is huge, but also we oftentimes become more sedentary. We need to maintain our strength training. And I think oftentimes we probably, as we get older, we might take the dog for a walk, or we might do, a Pilates class occasionally. Like, you would see plenty come through your door. But actually really having a focus on strength training and maintaining as much muscle strength as possible is super important. And quite easily, within 2 weeks of detraining, you can start to have some muscle weakness and a reduction in muscle strength. So it's really about how those muscles function. So if you've got changes in hormones, you're becoming more sedentary, not keeping strong in those muscle groups, so the hip abductors and the hip rotators, you'll start to alter the way that you walk and how stable the pelvis is when they walk. Stable meaning not that it's going to fall apart. I mean, stable as in you can maintain a level pelvis when you stand on one leg. If you don't have that, what we see is kind of a repeated compression. I think about compression being like a squash tendon. And if you keep squashing a tendinous structure, it doesn't like it and it responds in a reactive way. And its way of saying, hey, don't do that anymore, is discomfort. You asked a question around, what happens with tendinopathy? And you are right. Exactly that. You get lots and lots of cells. So I think about them sort of as, rather than having, the odd ant passing by, all the see thousands of them in your house. I think of those as cells. So that's, the upregulation of cells called tenocytes. When there is that upregulation, there's an increase in the protein content of a tendon, and proteins love water. So they'll actually draw in water into the tendon. And if you think about the tendon as like a piece of mesh or like a checkerboard, and you've got collagen sort of going over each other in a matrix form. So if you've got lots of tightly packed collagen and then you get lots more cells in that collagen, you've got lots of proteins and you draw in lots of water, it's going to create a situation where there's too much stuff in a small area and that can disorganize that collagen. So it can push it into different sort of positions, or, it's no longer this nice aligned structure. And it's that disorganization that then causes some sort of vascular ingrowth. They call it neovascularization. So nerves and blood vessels, essentially. And then from there, that can cause symptoms. It doesn't always cause symptoms. And that's where we differentiate between someone who has tendon pathology. So they might go and have an image done, like an X-ray, not an X-ray, an MRI. And that MRI says, they've got tendinosis or something like that, or some sort of tendon pathology. But that person says, I don't have any pain. Well, they don't have tendinopathy. They have tendon pathology. So that where there's a change in what the tendon looks like, but it doesn't necessarily mean the person has pain. And it's only when the person has pain that's aligned with those, perhaps that imaging that they've had and clinical dysfunction of that area, that it would then be classified a tendinopathy. What's awesome about tendinopathy, though, is there is a way out, and we can make it better by basically reducing how the aggravators to the tendon. So gluteal tendinopathy, tendons don't like getting squashed. So we reduce things like crossing our legs over each other, laying on our side at night, climbing stairs or ramps in the initial phase. We really try and stop anything that causes that tendon to get squashed or compressed. And then once we've made it feel a little bit happier, we can sort of start to expose it to, first of all, some strength training. But then as the person gets stronger, we can start to sort of bring in those activities that perhaps give it a little bit of compression. Because in the end, a tendon has to respond to the activities that we do in life. And we don't always, sit in a particular way or lay in a particular way. We're human beings that move in and out of different movements. And so we should. So whenever as physios we see someone and we restrict their activity or are really clear about what we don't want someone to do, it should really be in the short term while we get control of someone's clinical symptoms. And then once we've got control of the symptoms and they're starting to get stronger, we can then start to expose that individual to doing some social activities perhaps, or return them to, a gym exercise program that perhaps was originally a bit aggravating. We start to just load them back into their activities.
What about, does a glute stretch compress that tendon?
It does. It very much does. So
that's like you're crossing over, isn't it? Like sitting cross-legged, but it's a
Yeah.
glute stretch. So we shouldn't do that
Yes.
one. What about,
Yes,
the stretch when
that's
you
right.
stretch your hamstrings and then you go, I'm going to take it into a nerve stretch and you take it across. What about that?
Yeah,
Not
that's
doing that either.
exactly the same. So so initially, certainly while someone's symptomatic, we take away all sustained stretching that takes the hip across the body in any way, shape or form. So that might be things like,
That side
someone might
stretch.
go and do
You
a
push
yoga
legs.
class or
Oh,
side
yoga.
stretch, right? Yeah,
Pilates.
yoga or
Pilates is good, but not yoga.
basically any movements that squish the tendon, whether that be direct pressure, so laying on it,
Lying on.
or whether it be bringing the knee across the body. We need to get rid of anything that squishes it. It doesn't
Standing
mean
on
that has
one
to be
leg?
forever.
Is that standing on one leg?
So standing on one leg with muscles that aren't being recruited well and aren't strong enough will definitely compress the tendon if the muscles aren't strong enough to keep the pelvis nice and level while they're standing on one leg. So if they aren't and they're standing on one leg and their pelvis drops, they will be compressing the tendons on the outside. So generally in the initial phase, we'll do double leg based exercises and exercises that don't involve squatting too low, because sort of a deeper squat can also increase the compression of the outside of the hip. And then from there, oftentimes people don't get that, that stretch relief because we've stopped them from doing it.
Yeah, glute stretches.
So I generally then recommend they use, again, like they can still go to Pilates, they can still do their clinical exercises, but when someone else might be doing a stretch, they can get out their spiky balls and then use them through their glutes or lower back or wherever.
What about the foam roller along the side? Or we shouldn't do that? Or we shouldn't?
So you could use the foam roller along the front of the thighs, so the quadriceps sort of muscle group. But when you move it onto the side, it can push the leg almost across the body. So if they're sore, no, I would avoid that too. If it's someone who's never had discomfort, I have no problem in someone rolling out the lateral or the outside of their thigh. But what I generally suggest, because it is so common in sort of the middle-aged age group, I just try and avoid rolling over the big bump at the top of the hip.
Oh, yeah, don't roll that out. Yeah.
And I would stay below the bump with everyone, but particularly in those that are a little bit in a middle-age group.
And can it give that sort of Trendelenburg gait? That gait where you sort of have that hip dropping down or the sort of waddling from side to side type of thing?
That's right. So that's absolutely a Trendelenburg sign, and you're right, or a Trendelenburg gait, walking gait. So that's where you can't maintain that level pelvis. You generally see a pelvic drop on the other side, so that standing leg, those standing leg muscles are not strong enough when they land on the leg. So you're right, it does show a Trendelenburg sign. Equally though, rather than that, you can see like a teapot kind of effect where they'll bring their chest over the leg. And that is exactly the same. It just looks different, but it still generally has the same impairments.
And
Impairments meaning weaknesses.
so to try and remedy that, are we supposed to practice a walking gait with our clients, or are we supposed to practice just strengthening those muscles? And how do we strengthen them if we're not lying on the side or we're not standing on one leg? Like how?
Yep. Yeah, absolutely. So oftentimes I actually start rehab or make sure in a rehab program, someone a little bit more mature, include the calf and the quads. So the calf is around 60% of the propulsion of the lower leg or the lower limb. 60% of like the forces, I guess is probably an easier way to put it, come from the calf. So if you have a really strong calf, you therefore have to do less with the rest of your leg muscles. So while you reduce the aggravators, so the aggravators being anything that squashes the tendon, like your stretches, you really focus on getting some calf strength. So, for example, on a reformer, you could do calf raises on the reformer and put them on, say, you could even go up to full springs where you're moving through concentric, eccentric. So there would be no problem with that. Or like the prancing kind of exercise. Yep, absolutely. You could also work on the quadriceps strength. So the quads allow you to extend the knee. Sort of in sitting, you extend the knee. So on a reformer, for example, you could do your basic leg press. And again, you could build that up in its difficulty, but you could also restrict the range of it. So rather than going into sort of a deep squatted position on a reformer, you don't come in or you don't bring the carriage in as far. The other thing, so less than no. So you're not bringing it past a right angle.
Yeah, past that right angle.
So you're bringing it in, but not further than 90 degrees of the hip. That's an option. The other one you could do is like when you push the carriage out halfway, so your knees are sort of in that half bent position, and then you can move up and down and do a calf raise in that position, and that works the quads quite significantly, the distal quads.
Wow.
So there's lots of things on the reforming you can do. You could also work on the deep abdominal muscles, like I don't know what you call it specifically, like an upstretch. Or any of like your chariot pulls, bicep curls, anything like that where they're having to stabilize their body in high kneeling is all going to be helpful for these individuals, because when you're rehabbing someone with lateral hip pain, they need really strong calves, they need some good quads, some hamstrings would be very helpful. You can work on their gluteus maximus, so things like you could do on reformer or trap table, you could do any form of a bridge formation, plus or minus like a hip extension, so like a pelvic press kind of position. So all of that would be completely fine because it's double leg and not biasing the single leg. And then if you do single leg activities, I don't actually have a problem with single leg early on. In fact, it was an exercise that we used in our intervention study called a hip hitch. But it's really important that when you do that, you may need to take out the balance component of the single leg standing. So it might be, say, for example, you stand on one leg, you weight shift across, and maybe you're putting your weight of your upper limbs through, you might hold the sides of your trap table, for example. So you're reducing the balance, because tendons, they don't like getting squashed, but they also don't like receiving inconsistent information. So if you send, like a wobble through them and they're sore, they don't like it. Whereas if you stand on one leg, you're really balanced, it likes consistent information. So that's called an isometric contraction. So if you put the muscle and a tendon under load, so load meaning putting weight through it and using the muscle, if you give them consistent information, They usually can tolerate it, but if you give them inconsistent information, so you say you stand on one leg on a foam box, that will really cause discomfort in someone who has a reactive, angry tendon.
Thank you so much for listening to Art of Pilates. I'm your host, Louise Taube, principal trainer as recognised with the PAA, studio owner and Pilates teacher. To stay connected, please subscribe to my mailing list via my website, taubepilates.com. And if you've loved this show, please give me a review. I'd love a Facebook review or a Google review. It really helps to support me and my business and this podcast. See you next time, and keep moving with intention.